Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air-conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
Good morning, everyone. Welcome to this edition of the Hindu Wellness Webinar. Today, we will discuss advancements in bone marrow transplantation. We have with us three eminent panelists, Dr. Maman Chandy, a consultant in hematology at Naruvi Hospital, Vellore, Dr. Sanjay Bhattacharya, senior consultant microbiologist, Tata Medical Center, Kolkata, and Jayashree Shankar, Head of Search, Match and Transplant Services, Datri Stem Cell Donors Registry, Chennai. I am Sujata, a Deputy Editor in the Reporting Department of the Hindu in Chennai, and I'll be moderating the discussions. Dr. Maman Chandy is currently consultant in hematology at the Naruvi Hospitals, Vellore. He was the director and head of the Hematology and Bone Marrow Transplantation Service at Tata Medical Center, Kolkata from 2010 to 2023. Earlier, he was professor and head of hematology at the Christian Medical College, Vellore, till his retirement in 2009. He did his MBBS and MD in CMC Vellore and his hematology training at Westmead Hospital in Sydney. He was awarded fellowships of the Royal College of Physicians and Pathology of Australia. He is also a fellow of the Royal College of Physicians, London. He started the DM course in hematology in India, and under his leadership, the first bone marrow transplantation for thalassemia in India was done in CMC Vellore in 1986. He has been member and later chair of the Human Genome Task Force of the Department of Biotechnology in the Government of India. He received the Dr. B.C. Roy National Award in the category of Eminent Medical Person for the year 2008. The CIBMTR Distinguished Service Medal was conferred on him in 2014 for his contribution in the field of hematopoietic stem cell transplantation. He received the Padma Shri in 2019. Welcome, Doctor. Ms. Jayashree Shankar has over a decade of dedicated experience in the field of and specializes in donor workup and database management for adult blood stem cell donor registry. She has successfully facilitated comprehensive donor workup for numerous national hospitals and international registries, specializing in adult blood stem cell transplantation for patients battling blood cancer and related disorders. She optimized the coordination process, fostering efficient communication and collaboration among all these stakeholders, and is proficient in managing national and international donor search software, including the World Marrow Donors Association search and match services. She has a strong foundation in database management, agreements, project coordination, quality control, audits, content writing, and facilitation of orientation. Her passion for healthcare drives her to seek opportunities to contribute her versatile skills and knowledge to a dynamic organization like Datri. Welcome, Ms. Shankar. Dr. Sanjay Bhattacharya is an MBBS and has completed his MD, DNB, FRCS, and CCT from UK. He is now a senior consultant in microbiology at the Tata Medical Center, Kolkata. He is the chairperson of Hospital Infection Control Committee at the Tata Medical Center. He is the member secretary of the Biosafety Committee, again at Tata Medical Center. And he's also in the WHO working group in the area of priority pathology list. Again, he's in the working group of environmental cleaning in CARBA-resistant organisms. He's in the working group of landscape of diagnostics against antibacterial resistance in LMIC. All these in World Health Organization. He's also in the ICMR working group on biotechnologies SOP, antimicrobial policy. Then he's also in the working group of NCDC on infection control guidelines. He has around 145 publications, including 15 book chapters. His interests include molecular biology, clinical microbiology, infection prevention and control, medical education, and applied research. He has grants received from DBT, Department of Biotechnology, ICMR, and CDC. Welcome, Doctor. The first presentation will be by Dr. Maman Chandy, and then Ms. Shankar will make her presentation, and finally Dr. Sanjay Bhattacharya will make his presentation, after which we will take questions from the audience. Dr. Chandy, it's over to you.
Can you see my...
No, we can only see you, but not your presentation yet.
One. Any luck now?
Not yet, sir.
Not yet.
Yes. Oh, no.
Now?
No. Yes, now we can see it, sir.
Okay. Is that okay now?
Yes.
Okay, I'm really sorry for that.
Okay.
My brief in the next 10 minutes is to tell you something about bone marrow transplantation. But actually, what we are transplanting is not bone marrow in most cases. It is a cell. And that cell is what we call the hematopoietic stem cell. Now, in your body, you have cells which are capable of indefinite proliferation and self renewal. These cells are called stem cells. And this is an example of a stem cell which divides into two daughter cells, always puts one cell back into the bank, and then is capable of becoming monocytes, granulocytes, platelets, red cells, lymphocytes, and osteoclasts. Now, the monocytes and granulocytes are essential for you to fight infection, platelets for you to prevent bleeding, red cells to carry oxygen, and lymphocytes and plasma cells make up your immune system. Now, all these cells come from the hematopoietic stem cell, and that is what we are transplanting when we do a bone marrow or a hematopoietic stem cell transplant. This is Donald Thomas. He received the Nobel Prize in Medicine in 1990 for setting the stage for scientific bone marrow or stem cell transplantation. What is the principle of an allogeneic stem cell transplant? You have a patient. He has a disease which cannot be cured by any other condition. You have a donor, his brother, who's full matching. What do? You condition the patient. That means you destroy his marrow, destroy his immune system, and then take stem cells from the donor and transfer it to the patient. And if you've done your job well, you've replaced the marrow with healthy, normal stem cells, which can produce red cells or platelets or white cells, whatever you need for recovering the patient from his condition. In order to do a transplant, you need a match. And this is the HLA system. Each of us inherits one set of genes from our father and another set of genes from our mother. So this child has got A and D, A from dad and D from mom. And another child has got the same A and D, and these two are matched. But this child has got C and B, which means that he's totally mismatched with AD, whereas this child is half matched with this. Today, we can do half match transplants. They're more difficult, but full match sibling or related transplants are easier. Now, there is something called an autologous transplant where you have this patient, he's got a cancer, you've got a drug which will kill the cancer but will destroy the bone marrow. So, what do? Take out the bone marrow or the stem cells, freeze them and keep them, and then put them back after you've destroyed the cancer with intensive chemotherapy. And this is called an autologous stem cell transplant, where you take the patient's own stem cells. As I told you, any disease of the hematopoietic stem cell, be it a leukemia, be it a lymphoma, be it a platelet disorder, be it a red cell disorder, can be treated by a hematopoietic stem cell transplant. Now, in order to prepare a patient for a transplant, we have to destroy the bone marrow and the immune system. Now, we can do this with chemotherapy, or we can do this with radiation. This is a patient having a total body irradiation where we are trying to destroy the marrow and the immune system. Then our job is to collect the stem cells. Now, we can collect stem cells from the bone marrow, we can collect them from the peripheral blood, or we can collect them from the umbilical cord. These are the three sources of stem cells. Now, bone marrow transplant, as I told you, can be allogeneic, where we get the stem cells from a sibling or a related donor or a half-matched donor or an unrelated donor, and Jayashree will be telling you all about that. Twin transplants are called syngeneic transplants, and the stem cells comes from the bone marrow, the peripheral blood, or the cord blood. This is a bone marrow harvest being done. You can see that there are two doctors working on the pelvis of the patient. We are sucking out bone marrow into this needle, and we have to take great care to see that it does not clot. As we collect it, we then put it into a bag, straining out the bone spicules. Here again, there's anticoagulant so that the bone marrow doesn't clot. We keep a careful count, and then we check the number of stem cells, and we need 3 million stem cells per kilogram body weight of the recipient. Now, the other way of collecting stem cells is by giving a growth factor. So we give an injection of a growth factor, which is absolutely safe. We then put the patient or the donor onto a machine. Now, this is a donor who's donating stem cells for his brother who needs a transplant. So he just has to lie down, a needle is inserted, the blood comes into this machine, it separates out the stem cells, returns everything else back to him, and what is collected then goes up to the transplant unit. This is a little child with thalassemia, and you can see that's the bone marrow donated by his sibling. It's just looking like an ordinary blood transfusion. And the miracle of hematopoietic stem cell transplant is that the stem cells here will come into this patient, find their way to the bone marrow, settle there, and grow and reconstitute the hematopoiesis of the patient. All blood and blood products have to be irradiated because even any living cell from anybody else can attack the patient because he is defenseless till the immune system recovers. There are some complications of transplant. Infection is one of the biggest ones, and Dr. Sanjay will tell you why it's so important that we take care of our environment because we are all colonized with resistant bacteria. Sometimes the donor's cells detect differences between the recipient, attack the recipient, and this is called graft versus host disease. Now, in a kidney transplant, all you happen to do is you lose your kidney. But here, the donor cells can attack you. If they attack but don't cause damage, it's good because it will kill any remaining bad cell. The bone marrow can be rejected, and sometimes the original disease can come back. We give certain medicines to prevent graft versus host disease, and these two drugs are what we use. This is a patient with grade 4 graft versus host disease. It's like having a third-degree burn all over the body. Thankfully, this almost happens very, very, very rarely nowadays because we've learned better how to prevent this complication. This is the palm of a patient with graft versus host disease, a fair-skinned person, and it looks quite dramatic with redness. Now, after a transplant, you are a chimera, which means your self is the same, but your blood cells are all from your donor, which means if your donor was A group and you were B group before the transplant, after the transplant, you will now become A group. And this is an example of the Greek god Chimera. And in Hinduism, we have Ganesh, who is an example of a chimera. Now, you can check by DNA test to see whether all of the blood cells are now donor in origin. India does about 2,000 stem cell transplants every year, and we're quite proud that we maintain a registry and we document what each center, and this is done in about 100 centers. This is the transplant center in which I worked. This is one of the rooms where you can see outside. This is the nursing station. This is the cryopreservation laboratory where we freeze the stem cells in order to keep them if we need to keep. During COVID, we collected, kept, because we didn't want the donor to land up with COVID in the middle of the transplant when he needed the stem cells. Now, if you don't have a donor, what happens to you? You can have a cord blood transplant, and Jayashree will tell you all about matched, unrelated transplants. And haploidentical transplants are now being done where we're using a half-matched donor. Now, I don't believe that collecting baby's stem cells from the cord blood and freezing is really a valuable thing to do. It's expensive, and there's hardly any instance where those stem cells have really been used. Of course, if you have a patient with thalassemia and mom's having another baby, then it makes sense to collect the cord blood and keep it. India has 20 million people who carry the gene for thalassemia, and each year 10,000 children are born with thalassemia. These kids have a lifelong transfusion and iron removal, and this is one disease which we can treat with a transplant. This is Sabrinathan. He is 23 years old. He had his transplant when he was 13 years old. He's a computer engineer and he's leading a totally normal life. And that is what stem cell transplant can do for many diseases. Thank you very much.
Thank you, Doctor. I request Jayashree Shankar to please start her presentation. Dr. Chandy's presentation was like awesome. Thank you so much, sir. Learned a lot.
I think once Dr. Manan Chandy's screen is...
Stop, share 1 minute.
Yeah.
Done.
Yeah. So as Dr. Maman Chandy gave us now the reason for why we are in this webinar, I would like to reiterate a point that why we should be a blood stem cell donor. So while saying this information, as doctor said, for a patient battling any blood cancer or blood related disorder, their opportunity of finding a donor within a family is just a 25% probability. All these patients, apart from this 25% probability, they have to depend on the rest 75% with their extended family or a general public scenario, which we call as unrelated group, right? So these unrelated donors like you, me, the public forum, we have to provide an opportunity for this patient to first identify a donor for them, for which the primary first step is you to get registered into an adult blood stem cell donor registry. So once that registry is DATRI, it's a not-for-profit organization. The journey began in 2009, and we are India's largest blood stem cell donor registry with almost 5.4 lakh donors registered with us. Here, even though the count seems to be higher, and some of you get a wow factor like, okay, these many people have registered, but still, if you can see, as Dr. Maman said a point where in a country like India, where we have 1.4 billion people, and out of which we can see only 5 to 6 lakh people registered for a cause, then we don't see a probability for the patient, and we don't see an opportunity for this patient to find a match for them, right? So in that way, first we have to get registered into a database for you to be available for the patient, for which this registration process is very simple, which is less than 5 minute procedure. First, you have to attend an awareness session. One such session is happening right now that I am taking you through. Otherwise, you have to log in through the website www.datri.org. The eligibility is very simple, that you are between 18 to 50 and healthy enough to undergo the process. You fill up an application form. You give your primary details like your name, contact number, and your other details for us to contact in case if you are found as a match. And then you take a sample of buccal swab. This why we do is like for every blood donation, how a blood group identity is very common between a blood donation. Likewise, for you to donate your blood stem cell to a patient, your HLA, it is more technical term, but if we put in a layman term, it is your cell identity, your cell number. So that particular test has to be run. For this, we collect a cheek swab, which is a earbud kind of a cotton swab run into your inner cheek. This process is much simpler than you brushing up your teeth. So by the cheek cell swab, and we ship the sample for that particular HLA testing, and we get a report, and this particular parameter, the cell numbers are saved into the database. So a registry is all about keeping the donor information like the HLA and the primary information to find and to provide an opportunity for the patient to find a match. Like if you see this particular slide, there are group of numbers for the patient and there are group of number for donor. So these numbers should be same. Like how you can't wear a mismatched socks, right? You have to wear a pair of socks, right? So like this, between you and the donor, every number should be of a right match. And only when that is being found, then the actual process of you being a donor to them happens. And that happens like a patient submits a request to a registry to find, first they check within the family. If they're not getting a match donor there, then they come to registries like Datri. They provide their HLA report, which we cross-check with our registered donors HLA. And at the time we found a patient to be matching to a donor, that's the actual time that you even donate your blood stem cells. So the very first step of you being available to the registry is very important. And the second step will lead you to them being actually available for them at the time of their right space of their own need. So when we see the journey that we came across, here I would just like to represent the numbers. So even though we have 5.4 lakhs donor registered, if you see the products that we have serviced to the patient is 1250. So roughly the percentage is very, very low. So in country like India, for a patient who's of Indian origin, we need more of our donors, Indian-based donors, to get registered. Since our country is such a diverse country, we are segregated with languages, different dialects, and different biological traits, and we carry our biological traits, right? So in that scenario, while speaking about this, our vision and mission both are like we need to provide that particular space to the patient to find their donor, and also once a donor is found, we take utmost care on the donor to make sure that donation process is accomplished in a right way. And also, while speaking about all this, there are still patients who are waiting to find their match. Like once they don't find a match within the family, like the posters that you're seeing right here, these kind of patients, there are like, if I could say you a number, it's more than 4,500 patients still in our database waiting to find their full matched unrelated donor. So for us to provide them an opportunity, you could be a ray of hope to them, where if you get registered, at one point you will be found as a match to this patient. You can act at the time and you can gift them a life, which could be like, it will happen only if you take the first step of registering. So do register, make yourself available for these patients to get that hope of their life. Thank you, and please log on to our website to get registered and make yourself available.
Thank you, Jayashree Shankar, for this beautiful presentation. Dr. Sanjay Bhattacharya.
Yes, thank you, ma'am. I'm trying to actually
You're not visible. Please turn on your video. Yes.
Hope I'm
yes.
very visible
Yes.
now. Yeah. Hope the screen is visible now.
Yes, sir. Yes, sir.
Thank you, ma'am, and thank you to the Hindu group, and thank you, sir, for the opportunity to be part of this important webinar. Now, I'm going to share my experience of antimicrobial resistance, or AMR, in India with a microbiological perspective. Now, this happens to be the AMR Awareness Week. So it is called the World AMR, or Antimicrobial Awareness Week. And it is actually quite important for the general public and our citizens to understand the importance and the problems associated with antimicrobial resistance. So what does antimicrobial resistance do to our environment and to the healthcare? It leads to increased morbidity or suffering. It leads to increased mortality or death. It leads to increased length of hospital stay. It leads to increased healthcare expenditure. And it also leads to increased use of broad spectrum antibiotics. So there are multifaceted ways in which antimicrobial resistance actually changes the way in which we treat the patients. Now, why antimicrobial resistance matters to all of us? The first and foremost thing to understand is that there is a very high proportion of healthcare cost, including that in bone marrow transplantation, that occurs because of antimicrobial resistance. If a patient is found to be infected or colonized with resistant bacteria, then the possibility of the patient spending a lot of money for antibiotic treatment is significant. Second thing to realize is that antibiotic use in poultry and animal husbandry is a big issue in India. And what happens because of this antimicrobial use in poultry and animal husbandry? It enters the food chain. Antimicrobial residues can be found in food, as well as particularly animal food. And also drug-resistant bacteria can pass on to the animals and to the environment and eventually to humans. Infection with pan-drug resistant bacteria, which are called PDR, also becomes a reality in this kind of situation. And as the antibiotic resistant bacteria enters into the food chain and into the natural environment, the water supply which the humans actually consume may contain antibiotic resistant bacteria in traces, and that leads to colonization of the human gut with drug-resistant bacteria. So these are the major problems associated with antimicrobial resistance and why it matters to all of us. Now, antimicrobial resistant bacteria may be classified into various types. So there are so-called isolated resistant bacteria, which are actually resistant to one or two classes of antibiotics. Then we come to MDR, or multi-drug resistant bacteria, which are resistant to 3 or more classes of antibiotics. Then we have got XDR bacteria, which are resistant to almost all classes of antibiotics except 1 or 2 classes. And then we have PDR bacteria, or pan-drug resistant bacteria, which are resistant to all classes of antibiotics. So we have MDR, XDR, which are extremely drug-resistant bacteria, and PDR. And increasingly, it has been found that many of our patients and sometimes the general public are colonized with MDR bacteria in the gut. Now, in the bone marrow transplantation, which is the topic of today, how it changes the equation. Number one, it increases the length of hospitalization. Antimicrobial resistant bacteria are more difficult to treat, more expensive to treat. As a result, the hospitalization costs also go up. Number two, it leads to increased risk of intensive care unit admission. So if the patient is infected with a drug-resistant bacteria, the chances of complications, the chances of a transplant failure or graft failure is increased. It leads to increased morbidity or suffering to the patient in the form of organ dysfunction or complications of management. And it also can lead to non-response to the first-line antibiotic treatment. It leads to increased use of broad-spectrum antibiotics, and it is also an infection risk to other patients. So these are some of the complications of having drug-resistant bacteria, apart from the risk of death, which is increased in case of drug-resistant bacterial infections. So what are these bacteria? So there are a few bacteria which are of importance to us. So these are known as either gram-positive bacteria, gram-negative bacteria, or fungus. So antibiotic resistance can happen in different types of bacteria as well as in fungi. So some of the important names are MRSA, vancomycin-resistant Enterococcus, third-generation cephalosporin-resistant gram-negative bacteria, carbapenem-resistant gram-negative bacteria, and Candida auris. Candida auris is a multi-drug resistant fungus which has increased in proportion over the years. These are some data from the Indian Council of Medical Research, but the most problematic among all of these have been carbapenem-resistant gram-negative bacteria, which has been present significantly in organisms like E. coli, Klebsiella, Pseudomonas, and Acinetobacter, and among the fungus, Candida auris. So these bacteria are extremely dangerous and extremely difficult to treat when it comes to the management of bone marrow transplant patient. Now, this table shows you the approximate mortality, 30-day mortality in case of infections with resistant organisms. As you can see over here, that if you have an infection in a resistant organism in a cancer patient, the probability of a 30-day mortality is very high. It ranges anywhere from 30% to 60%, and these figures are no different between the developing countries and the developed countries. So, although the exact numbers are different, the proportion remains more or less similar between the two sets of countries. So there is a very high chance of the patient dying if there is an infection in a cancer patient with a drug-resistant microorganism. So these are actually some of the figures of daily cost of antibiotic treatment. Now, the figures on the red that you can see, these antibiotics are very frequently used in the treatment of MDR and XDR bacteria. And as you can see, that the daily cost itself is 6,000, 8,000, sometimes 20,000 or more rupees per day. Now, these antibiotics, to be noted, are not used single. So they are used in combination. So for example, we may use combined colistin with meropenem. We may combine tigecycline with other antibiotics. So the actual cost is very high. It's actually a summation of many of these figures. So is the case with regard to the management of drug-resistant fungi. As you can see here, these drugs like posaconazole, isavuconazole, casifungin, they cost thousands of rupees. And when we have infection with a drug-resistant fungi, a significant cost is in the management of these drug-resistant infections. Now, infection can lead to a situation where not only the patients have to stay more in the hospital, but they also have to pay more for the reasons that I have actually described in the earlier slides. So this is a study done in our center by one of the students. And as you can see, when there is no infection, the average length of hospital stay is about 4 to 5 days. Whereas if there is infection with a drug-resistant bacteria, then the duration of hospital stay increases anywhere between 18 days to 25 days. So one stays more and pays more when they have infection with drug-resistant bacteria. Now, see, these are some of the organizations within India which are working in the management and control of drug-resistant bacteria. These include the Indian Council of Medical Research, the National Center for Disease Control, and the Southeast Asia Regional Office of the World Health Organization. So these are the nodal centers and organizations which are working together for the control and management of drug-resistant bacterial infection through education to the healthcare providers to provide evidence-based guidelines for the management of these infections. So what has been India's approach to tackle antimicrobial resistance? Now, these may be divided into these following domains. These are called diagnostic stewardship. These are called One Health approach, antimicrobial resistance surveillance, infection prevention and control, and antimicrobial stewardship. So diagnostic stewardship is doing the right diagnostic test for the right patient at the right time, at the right cost, with the right sensitivity and specificity. One Health approach says that not only the human health is important, but the health of the animals, the control of the environmental pollution, these are also important because we share the same earth. AMR surveillance or antimicrobial resistance surveillance data helps us to formulate antimicrobial resistance, antimicrobial policies, which have to be implemented properly through antimicrobial stewardship. And without infection prevention and control, we would not be able to prevent the spread of drug-resistant infections in our population. So what India needs to focus on tackling antimicrobial resistance? This can be summarized as follows: provide safe drinking water, provide good waste management, not only biomedical waste management, but also general waste and industrial waste management, maintain food hygiene, prevent and control environmental pollution, particularly of rivers, agricultural land, water bodies, aquaculture and fisheries, control the use of antibiotics in animals, particularly in poultry and livestock, control agricultural use of antifungal agents, develop capacity for microbiology laboratories, because without it, you would not be able to actually identify and detect infections, improve infection control practices in hospital, implement antibiotic stewardship and diagnostic stewardship, and work towards development of new antibiotics through research and development. Thank you very much for your time and attention. I'm happy to receive questions and answer them to the best of my abilities. Thank you.
Thank you, Dr. Bhattacharya. That was really nice. We've been talking a lot about antimicrobial resistance, but then the basic requirements is safe drinking water and waste management, which we are still not concentrating on as a country. So we have a few questions that have already come in. And before we go into the questions, maybe we can start with some questions that we have of our own. So I'll start with Jayashri Shankar. So you were talking about matching donors for Indian patients.
Yes.
Why is it so difficult for an Indian patient to find a match?
So as of 2023, if you take, our Indian population is more than 1.4 billion, right? So
Yeah.
in that, the registered donor who are already available in any registry setup is like, it's 5.4 lakhs. So if you see billions to lakh, already we are not there. So in that content, any Indian patient, be it of Indian origin, either in India or in worldwide, they didn't find an opportunity first to locate their donor. So the answer for this is like for more people to get registered and provide that opportunity for the patient to find their donor first.
Okay. So Dr. Chandy, there is a question for you. Somebody on the online has actually, Narmada RP. So she says, is there an age registration for bone marrow transplantation? She's an all survivor Coimbatore, and she was treated by you in 1991. So I'm not sure if it is for you, but then I'm sure you would like to answer this question.
Yeah, I think I remember her. She is a bone marrow transplant survivor and she is doing well. And it's very happy for us as doctors when a little child whom you treated is now a young lady and you feel really gratified that they still keep in touch with you. So the answer for transplantation, what is the youngest age? I think even a 6-month-old baby can be taken for a transplant. What is the oldest age? In India, generally, we are little careful when we suggest transplant to anybody who's more than 60 years old. But I can tell you that in many Western countries, even fit patients who are 70 years old are taken for transplant if they really need a transplant, and the outcome has not been bad. Definitely not as good as a 20-year-old, but outcomes have been reasonably good for diseases which are otherwise fatal. So therefore, the answer is we are expanding the upper age limit by using gentler treatments and better ways of handling complications so that our results, even in older patients, are improved. So age is not a barrier. Biological fitness is. Sometimes you can be 50 years old and look 90 years, but sometimes you can be 70 and look like a 50-year-old person. So a biological fitness is what actually determines whether I will take a patient who is 70 years old for transplant.
Thank you, doctor. So there is a question here. Please give information about bone marrow cancer. That's what we've been talking. The whole webinar is about that, right? If I'm not mistaken.
Okay. So
yes, sir.
Bone marrow cancer is really not a term we use nowadays. The term we use is blood cancer, and any cancer of the blood cells is called a blood cancer. There are two basic types. One is acute myeloid leukemia, the other is acute lymphatic leukemia. You can also have chronic lymphatic leukemia and chronic myeloid leukemia. In fact, the commonest cancer in our country is blood cancer in our country is chronic myeloid leukemia. Children get acute lymphatic leukemia, and thankfully, with good chemotherapy, 90% of these kids can be cured, and only about 10% will require a transplant. So, blood cancer is what we're talking about. It can be acute or chronic, it can be lymphatic or myeloid, and there are treatments now. For instance, if you have chronic myeloid leukemia, you don't need a transplant. You can go on to a simple drug like Glivec and live a near normal life. So we've managed to convert some cancers into chronic diseases. Children with acute lymphatic leukemia, 90% can be cured, and only a few require a transplant. But acute myeloid leukemia in adults, more than 50% will require a transplant in order to be cured.
Thank you, sir. Here is a very specific question. I think it's a personal question, but he's an anonymous attendee. And they said, I have a baby girl of 5 months and she is affected by beta thalassemia. At what age does bone marrow transplant can be done for this girl? And once bone marrow transplant is successful, what will be her lifespan?
So the first question is, transplant can be done even at 6 months of age. I generally prefer to do transplant when the baby is 2 years old because it's much easier to handle a baby, and it is preferable not to wait beyond 10 years of age. So I think the ideal age for a child with thalassemia to have a transplant is between the age of 2 to 10, but 2 is excellent, not a problem at all. If the child is looked after well before transplant with proper transfusion and removal of iron, the outcome of transplant is as good as 95 What happens after a transplant? If the child has a successful transplant, at the end of 1 year, all medication is generally stopped if there is no GVH. Child can go to school, child can lead a normal life. And unlike a renal transplant where you're on immunosuppression for the rest of your life, in a bone marrow transplant, at the end of 1 year, if you don't have graft versus host disease, you're off all medication and essentially leading a normal life.
Wow. Thank you, doctor. Thank you so much. I think you've answered quite a bit of the questions that they have asked here. What is the age limit for bone marrow donation? Kidney transplant and cardiac patients can kidney transplant and cardiac patients give bone marrow donation?
So the age limit, if you see, for at the time of registration, you should be for an unrelated donor setup. Once you are not related or donating within your family, as an unrelated donor, you can register once you cross 18, and until you are in your 50, you can register into the database. But once registered, you being found as a match and donating for a patient, you cannot cross an upper age limit, which is 60. Since we need a healthy donor to get all the process running on to collect the blood stem cells from the donor and give it to the patient. And the second question being cardiac. So when a donor gets matched and we take the donor through the process of this donation, there happens a complete medical health checkup for the donor with a couple of hematological evaluation and some of the infectious marker disease. If there the donor is not cleared in any other parameter other than this cardiac also, the donor will not be taken further to the next level process of collection of the blood stem cells, which means cardiac is one of the major problems a donor cannot donate with.
Thank you, ma'am. Dr. Bhattacharya, there's a question here for you. Purushottaman Venkatratnam. So he is asked, the role of traditional herbs like turmeric, garlic in mitigating antimicrobial resistance.
Yeah, actually, there has been some research, I would say, from the non-allopathic systems of medicine about the use of herbs. But we who are practicing medicine in the allopathic system do not actually have the knowledge and the expertise to interpret these data. What is important is that these are potential cures, I can say generally, but if they are really helpful, that has to be assessed in a proper scientific methodology, both by testing it in the laboratories as well as through clinical trials in patients. So unless and until we have solid data, which is backed with thorough quality control, both in the laboratory setting as well as through clinical trials, we would not be able to actually use them in a scientific practice for the management of drug-resistant infections.
Thank you, sir. Another question is, in bone marrow transplantation, as we see this, drug resistance is more an issue with bacterial infections. I think he's making a statement. Again, this person is an anonymous attendee. So maybe you'll have to explain this.
Yeah, actually, it is true that majority of the infections in hospitalized patients and bone marrow transplantation patients and patients with blood cancers are no exceptions to that. These are bacterial infections. So 9 out of 10 infections which actually kill patients, which lead to hospitalization, are because of bacterial infections. Now, the worrying thing is that the proportion of bacterial infections that are drug resistant, that is not responding to the first and second line antibiotics, are increasing. And that complicates the management hugely. It leads to increased cost, increased toxicity, increased side effect, and leads to more drug resistance. So we are actually have a very difficult situation because many patients we find And Sir Dr. Chandy had actually started the process of doing a surveillance culture for drug-resistant bacteria in stool and throat swabs, where we found that patients who have had previous healthcare exposure, previous hospitalization, previous treatment, they are colonized with drug-resistant bacteria before even the transplant actually is done. So that shows that there is a fair chance of patients getting these drug-resistant bacteria from the environment, actually.
Okay. So there is one.
Sujata,
Yes, sir.
can I add a
Yeah,
small
please, sir.
point? A little child comes to me for a transplant from Hyderabad. He's never been ill before. He has thalassemia. He comes into hospital for his transfusion, nothing else. On the 7th day following his transplant, his blood count is 0. I come into the transplant unit and he is looking sick. He is breathless and his temperature is 103. And I feel that if I don't act immediately, I may lose this child. And I start him on ceftazidime, avibactam, astronam, 20,000 rupees a day antibiotics, and saved his life. But why? He is getting colonized with resistant bacteria. And 30% of Indians who are walking around healthy, normal people are carrying in their intestine bacteria which are resistant to most simple antibiotics and even the top line antibiotic. I feel that we will reach a point where we may not have an antibiotic and a patient will come in with an infection and die because of that infection. So we have to take care of our environment. Right now, the town of Vellore, raw sewage is going into the Pala River. And the Pala River is the main water supply for hundreds of thousands of people who live downstream of the river. How can we continue like this? We have to stop. There will be a time when somebody's child who's 10 years old comes in with appendicitis and has an infection from his own gut, not from the hospital, which is resistant to every single antibiotic. God forbid that India will take care of its sewage and water supply before that happens.
Thank you, doctor. Yes, that's a scary scenario. And I don't know. I don't have any answers to that except saying that you're right. And here is somebody, again, I think Purushottaman Venkatratnam, who's asked a question. Is there any opportunity for transplant from animals, especially pigs, where, as in heart transplant that was attempted recently, but I think both patients died after pig heart was transplanted, right? But then they
That's
have
correct. I don't think hematopoietic stem cell transplant is possible other than from a full matched sibling or relative or a half matched relative. I don't think it's possible. We cannot overcome the immune barrier. So, as far as I know, it's not done and it's not successful.
Thank you, doctor. Miss Shankar, I think they want, quite a few people want you to repeat the website where they can go and become donors.
So it is that www.dari.org. It's datri.org where you can go and register. I can provide the link of the same.
Okay, so there is a question here. Maybe you can answer this. Can regular blood donor registration, would it help in donation for bone marrow transplantation? I think that's what they are asking.
So regular blood donors know it more than a common public. So it's just actually the same process of how you're going to donate your blood, but here you're not donating your complete blood. You're just donating one of the component of the blood, which is a blood stem cell. As Dr. Maman says, it has undifferentiated activity. It can proliferate. Today, if you give, in a week's time, it can proliferate more. So you're not even giving your whole blood. You're just giving a part of a blood which can regenerate into your body in a couple of days ahead. So this is even more simpler than a blood donation is what I would reiterate here.
I think I want to second that, to say that bone marrow donation in the Lord, when I was here, we did 2,000 transplants, and in Calcutta, 700 transplants. And by God's grace, not a single donor had any problem. So it is not like donating one kidney, it's gone. Here, but even that is safe. Here, it's like giving blood. You're just giving some stem cells, and nothing happens to you other than you feeling good that you've helped save somebody's life.
Thank you,
Also,
doctor.
to add on, when we are speaking about related donation, right? When a patient gets a donor within the family, who is the donor? Think about that donor. It's just one other sibling that's going to donate for the patient. That sibling may be a 5-year-old, 2-year-old, 8-year-old. When they can undergo this process of blood stem cell collection, why an adult individual as us, the common public, could not? So I think this is the right time for us to rethink on it and then get to do this act of saving lives.
Thank you, ma'am. Dr. Bhattacharya, maybe you would like to take this question. What is the role of herbals like curcumin and grapeseed extract and Nitya Kalyani for treatment as anti-cancer agent? Would you like
I
to
am
take
not actually a cancer specialist.
Oh, okay, fine.
Maybe sir can take this on.
Dr. Maman, would you take this?
Actually, there is some data on curcumin,
Okay.
and there is a large trial which is going on now to look at whether curcumin can prevent cancer. In terms of treatment, the trials are not, we don't have any randomized control trial, but currently I know that in India there is trial going on to look at prevention of cancer with curcumin.
Thank you, sir. Here's one question from one Mr. Ahmed. Once bone marrow is done at a different age group, what is the surety that again cancer cell will not grow in the body metabolism? Because after treatment, we need to live with bacteria again in India. Is a good question.
Okay, so the question is a little complex.
I know.
So, where does can patients relapse? The answer is yes. After a bone marrow transplant for leukemia, yes, the patient can relapse. And the question is, does the relapse come from the donor stem cell or from remaining stem cells or cancer cells in your body which haven't been killed by either the chemo or the radiation or the donor cell going and attacking any remaining cells? So in the majority of cases, the relapse is from the patient's own cancer cell, which has not been destroyed completely, and where the donor's immune system hasn't been able to kill the cancer cell. In rare cases, the relapse is from the donor cell, which has somehow become leukemia, and that is extremely rare.
I would like to just add something with regard to infections.
Yes, sir.
As Sir said, that both the drug-sensitive and the drug-resistant organisms, and we are here concerned about the drug-resistant bacteria or antibiotic-resistant bacteria, they can colonize our gastrointestinal tract, our intestines, for a very long period of time. And there is no treatment available to get rid of the colonization of our intestine with this drug-resistant bacteria. So what may happen is that, so that is one of the reasons why we are so much concerned about control of environmental pollution and control of the water sources from pollution and our food sources from pollution. Unless and until we are able to control the pollution of these water sources and food sources, then we would not be able to actually make a difference in the overall incidence and prevalence of drug-resistant infections. One of the reasons why developed countries are doing better than us is because of their efficient strategy of preventing pollution of the environment, particularly water, food, soil pollution.
Ma'am, you are on mute, ma'am.
Sorry about that. There's a question from, thank you, Dr. Bhattacharya. Here is a question from one Avin Kumar, and he says, if I and wife is thalassemia minor, can we donate stem cells for my daughter who is beta thalassemia major? Will our stem cells match?
Usually, parents who are not related will only be half matched to the patient.
Okay.
But can a thalassemia minor child donate for a sibling who has thalassemia major? The answer is yes. In fact, more than half the transplants we do in our country, the donor, if it's a sibling, is a carrier and there is no problem at all. And the graft takes, the hemoglobin will be a little lower after transplant, but absolutely no problem at all. Can a half-match parent be a donor? The answer is yes. Nowadays, some centers in our country are doing half-match transplants even for thalassemia. They are a bit more difficult to do than full match. Full match would be ideal.
Thank you, doctor. So here is one question again from an anonymous attendee. In myeloma, is starting treatment with Darzalex the new trend? Is it not better to go the traditional way by treating with conventional drugs and then move on to other more expensive and recently added new drugs? That's the question.
So I think I'll answer that by first saying that in myeloma, there is a place for what is called as autologous transplantation. So after we give the patient some treatment, we then collect the patient's own stem cells, give him a high dose of melphalan, and then return his own stem cells. And that is known to prolong survival and disease control in myeloma. However, the question is about an antibody called Darzalex, and this antibody has now entered treatment. It's very expensive, but the question is really, when you're going into war, do you use your Bofors gun immediately, or you use a rifle and then leave the Bofors for the end? This is not yet sorted out completely, but we do believe now that hitting the cancer with everything you've got in the beginning and killing every cell is probably the way to go, but it's not been proven that 4 drugs, including Darzalex, to start with, gives you a longer duration of disease control. We need to wait another 2-3 years before that can be proved.
Thank you, doctor. So, G. Narasimhalu Gangappan, he actually says that there is well-established documentation that regular use of star anise seeds, Karunjeeragam, as a vaccination against cancer. So he wants your comments on it, but I guess he says he's already done some amount of research and he would like you to make a comment on that.
Yeah, I am afraid I have not seen a randomized trial, say, with adequate numbers of patients, which has shown that the daily use of aniseed can prevent a particular type of cancer. If the individual who's asking the question has such data and is happy to do it, I would have no objection, because it's a food supplement and it doesn't cause any harm at all. So doing something which causes no harm and might be beneficial is fine as far as I'm concerned. But if I were to start something, I'd require randomized control trial to show me that it's beneficial.
Thank you, sir. So there is Kamala Purushothaman. So he says, how much blood do you take from a donor and how much stem cells would be there in 1 unit of blood that you take? I think Jayashree Shankar should be answering this question.
Okay, so for a peripheral blood stem cell collection, we collect anywhere between 150 ml to 300 ml as a maximum for blood stem cell to be collected for an individual, and this is determined by the weight of the patient and also by the request of the hospital. Say suppose we are collecting a blood stem cell from a donor, and for a patient who the blood stem cells are going to be infused directly, then the volume is calculated according to the patient weight in that manner. If at all it's going to go for a cryopreservation and then a later infusion, then the volume is usually collected little higher to the determined volume. So this is basically with calculating with that of the patient weight, but the maximum would be 350 ml.
Thank you, ma'am.
Sujata, I can add a small point.
Yes,
that
sir.
inside the bone marrow, 1 in 100 white cell is a stem cell. Peripheral blood, less than 1 in 1,000 white cell is a stem cell. So our aim is to give 3 million stem cells per kilogram body weight of the recipient. That is our aim. So when we want to collect either from bone marrow or peripheral blood, we want to collect at least 3 million white stem cells per kilogram body weight of the recipient. So sometimes we may require to process 3 or 4 liters of blood for a 50 kilogram body weight patient to get enough stem cells to graft that patient. So that calculation, as Jayashree said, is based upon the weight of the recipient.
So my question here is, the body has only about 5.5 liters of blood. I don't know. I think that's what.
You're correct. That's right. We do not take out anything other than the white cells when we're doing a peripheral blood stem cell collection. All right. So when we give growth factor, your count now is 5,000. It may go up to 50,000, and the proportion of stem cells will increase from 1 in 1,000 to maybe 1 in 100. And therefore, from 2 or 3 liters of blood, we'll be returning everything back except about 150 to 200 ml, which contains the stem cells. So it's absolutely safe, and we've never had a problem. We never find that the patient's count comes down after a harvest. It never does.
Okay. Thank you. Thank you so much. So, Dr. Bhattacharya, there's one question for you here. Use of bacteriophages in lieu of antibiotics. Please offer your views.
Yeah, thank you for that question. Actually,
And
this has been going on for quite some time, that bacteriophages, which are a type of virus, they can kill bacteria. So, but the challenge here is that they have to be very specific. So that means for the different type of drug-resistant bacteria, you have to specifically develop these particular viruses. Now, there are not many centers in India which are actually doing this type of research. There is a center in Georgia, the former Soviet Republic, called the LVA Institute, which actually does phage therapy. So phage therapy as a principle works, but when it comes to the practicalities, it is quite challenging. So it is a potential cure. Many people have tried it, but I think because of the challenges involved in isolating the bacteriophage, developing the specific phages for specific type of bacteria, and you practically have very little time between the infection to effective treatment. Every hour delay in the management of a patient who is septic with a bacteria increases mortality by 5 to 7%. So you have to actually have these phages ready in your hospital to be delivered. Now, this is not possible for acute infections currently. It has been done for chronic infections, particularly some wound infections, etc. But in the scenario of the bone marrow transplantation, where the patient has very little immunity, you have to act fast. And we haven't seen much data about the use of these phages in that sort of situation.
Thank you,
Sujata,
sir.
if I can come in,
Yes, sir.
I've been trying to persuade Sanjay to have all these phages so that when a patient comes who needs a transplant and is colonized in his intestine with resistant bacteria, can we feed him phage and kill the resistant bacteria before we take him for transplant? This is the idea, but we haven't progressed with in terms of research in that direction.
Okay, sir. So maybe this question is probably for you, sir, Dr. Mammon. After CAR T therapy fails, what would be the next step in a myeloma patient?
Actually, the question is for
For
the rest
Dr.
of the audience.
Okay.
Today, we are developing therapies where we take out the lymphocytes of the patient
Okay.
and then we engineer those lymphocytes to go back and kill cancer cells. And that is called a CAR T cell, right? And it's extremely effective for acute lymphatic leukemia in children, where we take out the child's lymphocytes, we engineer them so that it will go back and kill cancer cells. And that process of engineering takes about 2 weeks. And this therapy is called CAR T cell therapy. For multiple myeloma, we have now got many different CARs which can go and kill myeloma cells. And this is a way of treatment. In fact, I have one patient who had every drug had failed. She had a CAR T cell therapy, and she's now 1 year after CAR T cell therapy, doing well, disease under control. So it can work. Now, suppose she relapses, then what will I have? Because every drug has failed. So at that point in time, I may try an antibody called a BITE antibody. And this antibody will go in and it will connect the T cell to the myeloma cell and kill. And in fact, now the debate is whether a BITE antibody will be just as good as a CAR T cell and maybe cheaper in controlling resistant or relapsed myeloma. BITE versus CAR, that is the argument.
Thank you, sir. There's one more question here. What is your opinion about dental infection during and after transplant?
I think that's very, very important. So, in fact, pre transplant, we do a very careful evaluation of the patient. We ask the ENT doctors to look at his ear in case there's a fungus sitting on the eardrum. We look at the sinuses because any of those areas, an infection can be a problem. And even a nail fungus infection. We had one patient who had an infection in the nail with a bug called a fungus called Fusarium, and post transplant, that Fusarium got into his bloodstream, and therefore we are very, very careful to check. In fact, all patients go for a dental check before they come in for transplant. They have a chest X-ray. In fact, Sanjay does surveillance microbiology so that we know what bacteria and what resistance pattern there is. So the question asked is very relevant. We do a very careful check of the patient to look for any focus of infection before we take him in for transplant.
Thank you, sir. So, another question. Please let me know why for some malignancies, we prefer autologous stem transplant and for others, allogenic. What is the concept of using autologous stem cells transplant?
Okay, the question is allogeneic transplant has various complications, and the most dreaded complication is that even though we are saying the donor is matched, when those cells come into the patient, they detect differences and they attack the patient's skin, liver, and intestine. And this is one complication which makes us reluctant to do transplant unless it's absolutely necessary. Now, certain malignancies, particularly in older patients, you can cure with an autologous transplant. So if you can kill the enemy with a pistol, you don't want to use a Bofors gun to kill the patient. Yeah, there is the enemy. And therefore, in a disease like relapsed lymphoma, 30% of the patients can be cured with an autologous transplant without the risk of graft versus host disease. So in specific diseases, in acute lymphatic leukemia, will an autologous transplant work? No, I will not do it. But in Hodgkin's lymphoma, which has relapsed, yes, 30% of patients can be cured with an autologous transplant. So based upon the disease, and the main diseases where we use autologous transplant today are in lymphoma and myeloma.
Okay. Thank you, sir. So I think this maybe Dr. Bhattacharya can take. Do you give prophylactic antibiotic to transplant patients?
Yeah. So actually, prophylactic antibiotics are given to transplant patients in Western countries where the proportion of drug-resistant bacteria is quite less. Okay, so antibiotics like ciprofloxacin are often given. But unfortunately, in our situation, practically majority of the bacteria that we find in the intestine, anywhere between 70% to 90%, are already resistant to ciprofloxacin. So the idea of giving prophylaxis and preventing infection is not applicable to our scenario. So that is one of the reasons why drug resistance is so much of an important problem in our country. So, the strategies that are applicable in the West are not applicable to our countries. And that is why we actually, Sir actually published a paper recently called Transplantation in a Zoo of Multi-Drug Resistant Organisms. So many of our patients, or majority of our patients, are colonized with multi-drug resistant organisms, and no prophylaxis is going to be effective in that situation.
Thank you, doctor. So there is one more question here, and then just two questions. After that, we will close the session. Can we do any differentiation on non-oncologic and oncologic patient in acute infection at peripheral region of tooth? I think this is in continuation to the earlier issue about dental infection. So Dr. Mammon, would you like to take it?
See, I didn't quite understand the question, but I think it was, is there a difference between...
Yes, I think that's what she's asking.
In oncology patients versus any other patient who gets an infection? And the answer is yes. In a person who's got cancer, his immune system is affected by all the treatment that he is getting, including radiation, chemotherapy. His nutrition is poor. So oncology patients generally don't tolerate infection the way a normal healthy person would tolerate infection. And the more intense the chemo, the greater the risk that infection will be the cause of death in a person with cancer. So that is the way I would answer that question. And I just want to say about what Dr. Sanjay said. When I trained in Australia, we used to try and sterilize the gut by giving all sorts of antibiotics. Okay. When I came back to India, I tried the same thing and realized that what was sensitive bacteria in the person's intestine, I now have allowed the resistant bacteria to proliferate. And where I had a mix of sensitive and resistant, now I have only resistant bacteria in the intestine. So we don't use prophylactic antibiotics in bone marrow transplantation.
Thank you, doctor. So there is only one more question. Why, this question of course is, why are there only 100 centers doing bone marrow transplant in India? I think the answer is pretty obvious, but still.
That's a tough question. But basically, bone marrow transplantation is not one individual's activity. If I'm a great plastic surgeon, I only need a nurse and an anesthetist and a theater. I don't need anything else. But to do a bone marrow transplantation, I need a whole team. I need a blood bank which can give me red cells, platelets. I need microbiology to tell me what infections I'm dealing with. I need to have biochemistry round the clock when my patient gets sick. I need to have nurses who are so dedicated to look after patients. I need to create a sterile environment where they're not going to pick up infection. And all this requires a lot of team effort. And that team effort and expertise, I must say, I'm thankful that in this country we're doing 2,000 transplants, but we're nowhere near the 20,000 transplants a year that are done in the US for a population which is 1/3 our population. So we need to ramp up our activity. We need to be able to do, but I think the trend is on the increase. And this 100 transplant centers is only those who are reporting to the stem cell registry, the Indian stem cell registry. There may be many more centers which are not reporting their data. We now have an Indian Society of Bone Marrow Transplantation, where 100 centers are reporting all their transplant activity so that we have a database. But I'm sure there are many more who are not reporting to the center.
Okay. Thank you, sir. And maybe one last question, because I think we are running out of time. So how many years post bone marrow transplantation can patients' immunity be compromised, especially post allo BMT?
I think
Allogeneic.
the answer to that question is within 1 year of an allogeneic transplant, if you don't have GVH and you're not on medication, your immune system essentially is normal. So 1 year is the time when you're at increased risk of coccal infection like pneumococcus. We give trimethoprim to prevent pneumococcus. But after 1 year, we pre-immunize the patient, which means you're like a baby. Your immune system has to see all the vaccinations that you, in fact, now have lost memory for. So we start with the tetanus and all those vaccinations. So for 6 months, we vaccinate an allogeneic transplant patient after the transplant. We start the immunization 1 year later, and by 6 months, it's all done. And in fact, a person who's 2 years post-transplant, who is off drugs, who has no GVH, his immune system is essentially normal.
Thank you, doctor. So there are a few more questions. Some people want to get in touch with you because they are interested in doing some kind of research. And the other question is the recording of the session available? Yes, it's available. It's there on YouTube. It's running live. And so you can always go back and check on YouTube. Thank you very much, doctors. Thank you, Jayashree Shankar, also for being on the program. It has been very interesting. Thank you very much, all.
Thank you, Sujata. And I want to thank Sanjay and Jayashree for taking time out. And I want to thank the audience for so many questions and for their interest in the topic. Thank you so much.
Thank you.
Thank you,
Thank
sir.
you,
And
everyone.
thank you, the Hindu group.
Thank you, Dr. Maman. Yeah.
Good.